Success? Okay, cool. So yeah, you know, it's fun to talk about gut and brain. I mean, it's interesting and it's relevant and it's understudied. And so thanks for being here. So these are our disclosures. I have been on the advisory board for Impel Neuropharma. All right, so what are we going to talk about? Start about what is the brain? What is the gut? What links the two together? We'll talk about gastrointestinal conditions and headache disorders. We'll examine the brain-gut connection as it relates to health and disease. We'll discuss factors associated with disrupted brain-gut homeostasis, explore the overlap between migraine and GI dysfunction, and we'll wrap up with talking about how it affects you. So how do gastrointestinal conditions affect my treatment of my headaches, or at least of my migraine? All right, let's talk about what's the brain. So I found these nice images. You can see my pointer when I do this. Cool. So this is a front view of the brain. This is a side view of the brain. This is the front of the brain. This is the back of the brain. So this tip here is this tip here. And so let's talk about some of the key components of the brain. So this is the cortex. So when most people talk about brain stuff, this is what they're thinking about. They're thinking about this outer layer. So the cortex is broken into two hemispheres, a left and a right. It's joined by a piece of tissue in the center that you can kind of see here called the corpus callosum. There's 4 lobes on each side broken down into 52 areas called Brodmann's areas. They're kind of functional, and they were figured out a long time ago based on when people would have a stroke or when something bad would happen and get a hammer to the head, you know, a lot of, you know, trauma related things, and certain parts of the brain were damaged. They could go, what is the person missing? And so over time, we've understood more and more, but this is how it's broken down into 52 areas of function, although there's a lot of overlap. So the cortex is involved in receiving and processing sensory information, vision, hearing, touch, as well as motor, so movement, as well as a variety of other activities, planning, actions and movement, and abstract thought. Next, we can talk about the brainstem. So there's the midbrain, the pons, and the medulla. So the brainstem is broken into those 3 parts. It has important roles in regulating heart, lung function, sleep cycle. There's 12 cranial nerves. There's 12 nerves that come off of here that go to the various parts of your face. And as we'll talk about later, and Dr. Nguyen will go into in more detail, is one of the cranial nerves that comes off the brainstem is called the vagus nerve. And that goes and innervates and controls your gut function, or at least that's one of the key controllers. Cerebellum is the other part of the brain that I wanted to talk about. It's important for motor control, including coordination, precision, and timing. So cortex, brainstem, cerebellum. This is the cerebellum that you can see through here. And the vagus nerve, which comes off the brainstem, is something that we're going to talk about later. It's always fun to know some kind of factoids about different things. They're intriguing. So sperm whales have the largest brains, 17 pounds. Your brain weighs 3 pounds. A beagle's brain, I don't know if anybody has a beagle, half a pound. Neanderthal brains were bigger than ours. Albert Einstein's brain was 10% smaller, although he did have higher neuron density. A 2-year-old brain is about 80% of adult size. Your brain comprises 2% of your total body weight, but uses 20% of its energy. Your brain is mostly water. There are as many as 10,000 different types of nerve cells in the brain. A piece of brain tissue the size of a grain of sand contains 100,000 neurons and 1 billion connections. Neurons can transmit signals at faster than an F1 race car, and can transmit 1,000 nerve impulses per second and make 10,000 contacts with other nerves that it's adjacent to. Oh, final one, I just added it. The supercomputer called the Spinnaker, made a few years ago, contains 1 million processors, and it can only approach 1% of the brain's, the scale of the human brain. So it's pretty impressive what our brains can do. Let's talk about the gut. So we talked a little bit about the brain. Let's talk a little bit about the gut. What is it? So starting from mouth to anus, so esophagus, so about 10 inches long in an adult. Its functions include peristalsis, so the movement, the slow contraction of food from top to bottom. It contains sphincters to prevent reflux of gastric contents, both at the top and the lower end of the esophagus. The stomach. So the stomach has, it's in the left upper part of your abdominal cavity. Functions include breaking down food, using acid and other things to break down proteins. It also squeezes and peristalsis, and it begins the process of absorption. The small intestine, there's 3 parts. The Dow Jones Industrial is how I remembered it in medical school, duodenum, jejunum, and ileum. Its functions include, it's the main site for absorption of products of digestion into the bloodstream, including sugars, proteins, fats, and vitamins. The large intestine consists of the cecum, which is the beginning of it here with your little appendix coming off of it. So the large intestine functions include absorption of water and the remaining absorbable nutrients from food before elimination, absorption of vitamins created by bacteria, and it compacts and stores feces prior to elimination. And finally, the rectum and the anus stores and controls expulsion of feces. Some factoids about the gut. You got some about the brain. Let me tell you some about the gut. It's about 30 feet long from top to bottom. It takes about 4 to 5 hours to for the stomach to empty and 30 to 50 hours for food that you eat to exit the body as stool. The gut has multiple functions, including breaking down food, absorbing nutrients, expelling waste, important immune functions, drug metabolism, and others. And it has its own nervous system. It can operate independently of the brain. It's often referred to as the second brain. When the vagus nerve is cut, that was the nerve, the cranial nerve that we talked about coming off the brainstem. The nervous system of the gut can continue to operate. 90% of the nerves in that, 90% of the individual neurons that travel through that larger nerve transmit information not from the brain, but from the gut to the brain. In other words, it's not what you would think that the brain's controlling the gut. 90% is actually from gut to brain. And 95% of the neurochemical serotonin and 50% of the body's dopamine is contained within the gut. The gut also contains microbes that can break down molecules, which is important because some of their functions, some of the things they can break down, we don't have the enzymes otherwise in our body to do, so we rely on them to do the work. So you know a little bit about the brain, you know a little bit about the gut, but what about how do they communicate? What links them together? This is a complicated slide, and the only reason that I put a complicated slide up is because it's complicated. And you can see that you got brain here. I'll orient you, and I'm not going, the details of this slide don't matter. The take-home message is that there's a lot of modes of communication that I like to break it down into 2 important ones. One is a direct nervous connection, nervous system connection. So the cranial nerve, the vagus nerve connects, this is the gut, it's just blown up, and it's that's where the microbiota are in it. So the vagus nerve connects brain to gut. There's also some nerves that come off the spine, off the spinal cord that involve control of the gut as well. So method 1 that the brain can control the gut is a direct literal nerves connecting brain to gut. The second main mode of communication is stuff that is floating in the bloodstream. So stuff that the brain makes, like hormones, or stuff that's made in the lumina of the gut, like serotonin, or doesn't list other things. It lists a bunch of bile acids and these other proteins, short chain fatty acids. So those are the two ways that I think about it: direct nervous system connection and stuff that's made and by one or the other that floats in the bloodstream, either brain to gut or gut to brain. This slide, I'm going to talk a little bit about the microbiome here, and it's a little bit out of place. I just want to put that up front, but it kind of makes sense in this location too. So I talked a little bit about the microbiota, the organisms that are in the gut. Let's talk a little bit about the microbiome. So the microbiome is defined as a microbial community. It's more than bacteria. It includes protists, fungi, and viruses, archaea, and they occupy a habitat. So you don't just have one microbiome, one group of organisms that inhabits your gut. You actually have a different makeup of organisms in different parts of your body. So your oral cavity has a different makeup of organisms than your esophagus does, than your colon does, than skin or vagina. So, you know, the organisms are kind of specific to their area. Your pets have their own microbiome. Soil, it's not just living organisms. Soil has a microbiome. So does the forest. So does coral reefs. So the concept is a group of organisms that live in a discrete area. The microbiome has been linked to various neurologic and psychiatric diseases. So some of the neurologic diseases here include MS, Parkinson's, Alzheimer's, Huntington's, ALS, psychiatric diseases, depression, anxiety. You notice that migraine is not on this list quite yet. This is where, you know, some of the work that we're doing at University of Vermont, we're looking at migraine and the microbiome, and we're doing a clinical trial that is going to be included after the session that we're actually recruiting, and we're sending out stool kits to people. So thank you for allowing me to plug my study. If you're interested, you'll see the contact information in the follow-up email. Let's talk about gastrointestinal conditions and headache disorders. So we know a little bit about brain, we know a little bit about gut. We know that there's multiple modes of communication, particularly a direct nervous system communication, and also stuff that can be made by either gut or brain and float through the bloodstream to the other. So now, what is the effect of those communications? So start from young to old. So infantile colic. So infantile colic is defined as crying and fussing for more than 3 hours a day, more than 3 days a week, for more than 3 weeks in an otherwise healthy and well-fed infant. Infants born to mothers with migraine are 1.5 to 2.5 times more likely to have colic than those born to mothers without migraine. And children with migraine were greater than 6 times more likely to have experienced colic as an infant. So infantile colic is more common among people with migraine. Interestingly, that association was not found for tension type headache. So that's interesting that our sort of classification scheme, the ICHD, kind of bears true here. That's interesting to me. Cyclic vomiting syndrome. So stereo is defined as stereotypical recurrent severe episodes of nausea and vomiting without headache, interspersed by symptom-free periods. About 1 to 2% of children are affected, often around 5 years of age, with a slight female predominance. 82% of kids with cyclic vomiting syndrome had a family history of or subsequently developed migraine themselves. And kids that have cyclic vomiting syndrome commonly progress to having migraine the way that we think about migraine later in life. Abdominal migraine, this is another typically childhood event, though it doesn't have to be. Stereotypical recurrent attacks of moderate to severe abdominal pain without headache again, interspersed with symptom-free periods. 2 to 4% of kids are affected, often around a little after cyclic vomiting syndrome, typically around 7 years of age, with a slight female predominance. And similarly, these kids commonly progress to developing migraine the way that we think about it later in life. So far we got infantile colic, cyclic vomiting syndrome, and abdominal migraine. Irritable bowel syndrome. It's a chronic functional bowel disorder characterized by altered stool form or frequency in association with abdominal discomfort or pain, traditionally divided into 4 subtypes. So a more diarrhea subtype, more constipation subtype, a mixed or an unclassified. The Rome criteria is kind of like we have international classification of headache disorders. There's also a group that meets, I think, in Rome and comes up with criteria for bowel disorders. And there was a Rome 3 and then more recently a Rome 4. So that's why there's different prevalence of irritable bowel syndrome is between 4 and 9%, depending on which criteria you follow, the more current one or the older one. And irritable bowel syndrome is between 2 and 2.5 times more common among people with migraine. And in the headache clinic at the University of Vermont, I have many patients that come to me for a headache disorder that also have diarrhea or constipation, which sometimes comes up in our discussion of treatment. And I say, hey, have you ever talked with your primary or a gastroenterologist about irritable bowel syndrome? And quite frequently, this is something that is not mentioned, I think, by a lot of patients. It has to be asked for, and so, but it's quite common, and 2 to 2.5 times more common among people with migraine. I wonder if that's an under prevalence, but that's what's been shown. Functional dyspepsia is characterized by pain in the upper abdomen, characterized by an early satiety in the absence of structural problems. So the prevalence is about 10% in the general population. In one study of people that they took just people with functional dyspepsia and say what percentage of those people had migraine, and 68% had migraine. So 10% in the regular population, but among people with functional dyspepsia, 68% had migraine. That was in one study. Gastroparesis. Gastro is stomach and paresis is failure to move. So gastroparesis is a chronic motility disorder of the stomach that involves delayed emptying of solids and liquids without evidence of mechanical obstruction. Common symptoms include nausea, vomiting, and early satiety. You might notice that a lot of the symptoms of functional dyspepsia overlap with gastroparesis, which is something that Dr. Nguyen will talk about. Gastroparesis has been observed among people with migraine during attacks and possibly between attacks. I am going to turn it over to Dr. Nguyen at this point, so I'm going to stop share.
Okay, thank you very much, Dr. Sprouse Blum. I'm just going to take a moment to give a little bio on Dr. Nguyen. She's a clinical professor of medicine at Stanford University, and she is clinic chief in the Digestive Health Center. She completed her medical school training at UCLA and GI fellowship training at California Pacific Medical Center in San Francisco. Her clinical and research interests include GI motility disorders and disorders of gut-brain interaction, with an emphasis on gastroparesis, what we were just hearing about, functional dyspepsia, and chronic abdominal pain. Her current research includes identifying biomarkers to better diagnose motility disorders, understand the role impact of physiologic testing on clinical care, exploring novel therapies for gastroparesis, and expanding the role of in the treatment of GI motility disorders and pain. She is also passionate about quality of life, professional development, and physician wellness. So welcome, Dr. Nguyen. And I just want to say before you start, we are going to take questions. So please, you can put them in the chat If it's something of a personal nature, you don't want your name to be linked to, you can send it directly to me. When you click on the chat, you can find my name and you can send me the question. I will not say your name and we can read the question. So please, Dr. Nguyen, thank you.
Great, thank you for having me and allowing me to talk about one of my favorite topics is the brain-gut connection. And Dr. Sprouse Blum talked about the science and how the brain and the gut are connected, but we know this deep down and it's in our language, right? So we say things like, listen to your gut. What does your gut say? It's gut wrenching. What's your gut reaction or your gut instinct? So we know that the brain and the gut are connected based on just our everyday language. So just to further expand on the disorders of brain-gut connection, which was touched on earlier, and the Rome Foundation really worked to classify these conditions to help with research. So they're not meant for clinical diagnosis, but more for clinical research. And we used to call them the functional GI disorders, but because of the negative connotation of functional, recently it was changed to disorders of gut-brain interaction to really highlight that there is a disruption in this homeostasis between the brain and the gut. The term functional GI disorders, it's embedded in our everyday language in terms of medicine. So you'll hear me use this word interchangeably. But when I think about function, when I talk about gut disorders being functional in nature, it's because it's not affecting the structure. So everything looks normal, but it's affecting the function, how the gut is working to, take the food as soon as you swallow it to elimination. And these disorders of brain-gut connection can affect anywhere from the esophagus all the way down to the anal rectum. And I'm not going to go over these conditions in detail, but just so you know that it's not just the stomach, it's not just the bowel, it's the whole gut. And how prevalent are these DGBIs? And it depends on if you're using internet surveys or if you actually go in and ask the questions. But if the household surveys were actually researchers going into homes and asking the questions, and the prevalence is about 20%, over 20%. So over 20% of essentially the world has one of these DGBIs, and the most common is constipation, functional dyspepsia, followed by irritable bowel syndrome and diarrhea. So we don't talk about it because it's thought to be embarrassing. It's not very sexy. So when you're at dinner, you don't really talk about your bowels with your friends and family, but it's out there. So a little bit more about the brain-gut connection. So as Dr. Sprouse mentioned, that there is this complex connection between the brain and the gut. And when it's functioning normally, you're not aware of it. As soon as you decide what to eat, chew it and swallow it, your gut and your brain takes over and you don't do anything else to it. You can't will your stomach to contract. Any alterations in the brain or the gut can set off a spiral effect that can further exacerbate symptoms. So for example, if you have a gastroenteritis or food poisoning, that can lead to disruption in the permeability, the microbiome of the gut, cause GI symptoms, but that in turn can affect mood, cognition, and sleep, and further the cycle. Brain conditions such as migraine, lack of sleep, chronic stress, I'm a little bit stressed because I have a deadline, but chronic stress, prior trauma, all those things can lead to increase in cortisol inflammation that can affect the gut, lead to GI symptoms, and again, a kind of a snowballing effect. And this is mediated through that vagus nerve or the autonomic nervous system, where the vagus nerve is part of the parasympathetic nervous system. But we also have to not forget that there's the sympathetic nervous system, which is the fight or flight response, which is where the stress comes in. So chronic stress increases that sympathetic activity, and increased sympathetic activity decreases GI motility. And in turn, that leads to decrease in the parasympathetic activity, which is your rest and digest. So the sympathetic and parasympathetic nervous system works in a balance. So it's sort of a up and down. You don't want one all the way up. You don't want your parasympathetic all the way up either. There's a balance there. And disruption in the autonomic nervous system can lead to various physiologic changes. For example, increase in cortisol, activation of mast cells, release of neurotransmitters. All these work together or fight your body's homeostatic mechanisms. So how does chronic stress, oops, sorry, I'm having trouble with my mouse here. So chronic stress does alter this homeostasis, and you can see here in terms of the sympathetic and parasympathetic innervation of the visceral organs, and that includes your eyes, your heart, your lungs, and your digestive system. And what we see here is that because there is autonomic control of the gut, any disruption of the autonomic nervous system can lead to chronic GI symptoms, and it's been described in gastroparesis, functional dyspepsia, cyclic vomiting syndrome, and IBS. And as we look at different conditions, we're finding that there are autonomic abnormalities. And then if you look at it the other way, individuals with autonomic dysfunction will complain of GI disorders. So in various studies, up to 80% of patients with dysautonomia experience some form of GI symptoms, with nausea and vomiting being the most common. We've touched on gastroparesis or slow stomach emptying, but rapid gastric emptying or too fast emptying is also not good, which can lead to the similar symptoms of delayed gastric emptying. And so when we've looked at our patients with gastroparesis or idiopathic gastroparesis, meaning that we don't know what caused or what triggered the gastroparesis, we find that migraines are very common, or actually even all the other chronic pain conditions. So like endometriosis, fibromyalgia, chronic fatigue syndrome is more common in patients with gastroparesis than the general population. And those with migraines tend to have more severe gastroparesis symptoms than those without migraines. So just to kind of take a step back, because we've thrown out terms of gastroparesis and functional dyspepsia, and there's a lot of overlap there. As mentioned earlier, gastroparesis is delayed gastric emptying without an obstruction, and you see the symptoms of nausea, vomiting, bloating, early satiety. But that's very similar to functional dyspepsia, and in various parts of the world, functional dyspepsia and gastroparesis are actually combined together, and gastroparesis is not recognized. And there's two types of functional dyspepsia. There's the meal-related symptoms, the symptoms that are triggered after eating, and then there's the burning pain that's not related to eating. And when we've looked at patients with idiopathic gastroparesis, 80% will meet criteria for functional dyspepsia, and predominantly the postprandial distress syndrome. So there's a lot of overlap there, and it's out of the scope of this talk to talk about the nuances of those two. But what's the relationship between gastric emptying and migraines? And this study looked at compared to gastric emptying. So you can measure how fast or how slow the stomach empties through a nuclear medicine test. And they looked at migraineurs versus non-migraineurs. And then in the migraineurs, looked at the ictal period versus the period between migraines, and found that at baseline, 80% of migraineurs met criteria for kind of delayed gastric emptying intraictally. And then migraineurs had slower gastric emptying than the control population. So overall, even when you're feeling well and not having a migraine attack, the stomach is emptying slower than the average individual. When you look at cyclic vomiting syndrome, and I tend to think of it as a version of migraines, but instead of headache, it's nausea and vomiting. And the most common therapy we use for treatment of cyclic vomiting are a class of medications called the tricyclic antidepressants. But when we look at responders versus non-responders, individuals with migraines do not respond well to tricyclic antidepressants compared to those without. As mentioned earlier, those individuals with migraines have a higher risk of IBS. But in this study where they followed individuals with migraines over time, even if one did not have IBS to start, there is a risk of development of IBS as the years increase. Again, just to highlight sort of a different view of this link between the DGBIs and migraines is that there's a lot of overlapping physiology here. I'm not going to go into the details of the arrows here, but you can see the words are very similar on both sides. One is DGBI, the other one's migraines, but the kind of common alterations we see are altered gut microbiota, autonomic dysregulation, kind of increased inflammatory mediators, and abnormal serotonin response. And so because of that, and as Dr. Sprouse Blum mentioned, that there's a lot of serotonin in the gut, and as gastroenterologists, we've learned to borrow from brain doctors, so from neurologists and psychiatrists. So we approach DGBI by using neuromodulators, so very similar to medications that are used in migraine or headache disorders to kind of affect the neuromodulation, so the nerves in the periphery, so at the level of the gut, and then centrally in the brain and spinal cord. And one of the common things that we see is that 40 to 80% of patients with DGBI have this hypersensitivity, what we call visceral hypersensitivity, meaning that there's a lower threshold to pain or discomfort. So for example, if you're at Thanksgiving dinner and you eat that third piece of pumpkin pie, you're going to have pain. Those with visceral hypersensitivity could feel pain not with the third piece of pie, but with the first or second bite of a pie. So just a little overview of kind of the different classes of neuromodulators. And this is more along the lines of not necessarily one is better than the other. The way I look at it is sort of looking at the GI effects. What do these therapies do to the gut motility, sensation, and secretions? How does it impact symptoms? And then looking at side effects. So for example, the tricyclic antidepressants, which I mentioned earlier, we use for GI pain as well as migraine. It decreases motility, and it can cause dry mouth and constipation. So if someone already has constipation to start out with, I would not use this therapy. As I mentioned earlier, we're great at, as gastroenterologists, we're great at borrowing or stealing from neurologists. So this is a study that we did looking at a handheld vagal nerve stimulator that's FDA approved for migraine and cluster headache. And we tested this in a small group of patients with idiopathic gastroparesis. And we found that chronic use of this therapy helped to decrease gastroparesis symptoms, as well as a trend towards acceleration of gastric emptying. So it's not to say that this is the therapy for gastroparesis, but to show you that, some of the therapies that are used in migraine could potentially help in the DGBI conditions. And then lifestyle. So I'm a big proponent of, lifestyle modifications and quality of life. So you can't talk about lifestyle without diet, sleep, and stress management. And sort of, to talk in terms of talking about food, oftentimes, especially when you eat something and it triggers symptoms, that there's this quest to find out, like, what's the trigger? Is this an allergic reaction? These studies are the studies are limited, and some of the common foods that have been found to trigger migraines are processed foods, histamine, nitrates, tyramine, foods that are high in fat. But in a survey where patients kind of filled out whether or not these specific foods cause symptoms or they weren't sure, majority of patients found that there was really no effect with these foods on their migraine. This study looked at using kind of a IgG-based elimination diet. So kind of a blood test to look to see if you may have these antibodies to certain foods and see if elimination of these foods could lead to decrease in headaches. And it does seem to decrease the headache count and headache days. That being said, I caution and kind of be aware of dietary therapies because there is an increasing recognition of a condition called ARFID, which is avoidant restrictive food intake disorder. It's kind of like an anorexia, but not because of body dysmorphia, but because of the effect of, when you eat and it causes pain or discomfort or any symptoms, in terms of protecting yourself, you tend to avoid that, but then that can lead to an ultra restrictive diet and an unnecessary fear of food. So there are two types of ARFIDs. There's this, sensory sensitivity, so just kind of a fear or aversion of foods, or a heightened sensitivity to like the different texture or taste or smell. So then there's sleep. More so in IBS, in terms of my awareness of the literature, is that patients with IBS, over 50% will have some form of disordered sleep, and lack of sleep or disordered sleep leads to autonomic dysregulation, and so can further worsen the severity of IBS symptoms. But even in those without IBS, having disordered sleep increases your risk of developing subsequent IBS symptoms. And this is a study not specific to IBS, but looking at just chronic pain in general. And they found that disordered sleep was associated with opiate misuse. And for every 1 hour increase in the nightly sleep, it decreased the odds of opiate misuse by 20%. So
I can take it. So I'm just introducing this last bit, and then we'll have questions and answers. So the last part is kind of where the rubber meets the road. I think that's the saying is, so how do gastrointestinal conditions actually affect my treatment? And Dr. Nguyen and I will kind of go back and forth on this bit a little bit. You can go ahead, Dr. Nguyen.
Yeah. So, in terms of GI considerations when treating migraine, so this is, conversations to have with your neurologist or primary care doctor is you really want to think about the presence of GI symptoms and, kind of take survey or note what symptoms you have. The presence of gastroparesis or diarrhea may impact absorption of oral medications. When I think about choosing therapies, I try to choose therapies that may have dual benefits. So again, going back to the tricyclic antidepressants, if someone has IBS, diarrhea, and migraines, because the TCAs cause constipation, if you're having diarrhea, something constipating is helpsful. If someone has gastroparesis and migraines, I may prescribe the non-invasive vagal nerve stimulator. And then as a gastroenterologist, I review GI meds that may worsen headaches. If my patients come in with headaches, I may limit their use of ondansetron, because ondansetron, chronic frequent use can lead to migraines. Nitrates or nitroglycerin, which I use a lot for kind of esophageal spasms, can worsen headaches. The question that we don't know yet is whether or not, if you treat the GI symptoms, does it improve the migraines and vice versa. And then,
Question, Dr. Nguyen, sorry, what's ondansetron?
Zofran.
Okay, thanks.
So, sorry, I try not to use the commercial names, but the commercial names are so much easier to pronounce. And then as you think about starting the therapies, you want to consider the side effect profile of the migraine therapies that may cause GI symptoms or worsen GI symptoms. So again, the tricyclic antidepressants, calcium channel blockers like diltiazem, the new CGRP antagonists, they can worsen constipation. Magnesium, which is often used for migraines, can worsen diarrhea. And then think about lifestyle modifications that we talked about earlier. And Shirley, I'm glad you talked about the stress modification and mindfulness therapy in migraines. In GI disorders and DGBIs, gut-directed hypnosis, cognitive behavioral therapy, guided imagery, mindfulness, biofeedback, emotional awareness training, all these types of brain-based therapies have been found to be effective in DGBIs. Most of these studies have been done in IBS. What's been intriguing is the fact that even when you stop doing the therapies like hypnosis, you can still have a lasting effect up to 1 year later. There's been no head-to-head comparison of these therapies, so I can't tell you that hypnosis is better than cognitive behavioral therapy. The challenge here is that there's still stigma with brain-based therapies, especially when you're dealing with a condition or conditions that you don't have a good biomarker for, or there's no structural abnormalities. And then there's cost and access. So finding someone to do gut-directed hypnosis is challenging.
I was going to talk a little bit about probiotics, and I'll mention prebiotics for migraine because this comes up fairly regularly. So there were a couple of randomized control trials. So a randomized control trial is what people think about when they think about drug studies. You have two pills and they look the same, and one is drug and one is not drug. And you give it to people that are randomized to receive either one or the other, and you look at some outcome. And that is the gold standard for how drugs are vetted by the FDA, and that is the gold standard of how clear answers to questions can be derived at, just because there's a lot of biases that can be introduced by investigators, and we all want our stuff to work, and sometimes we introduce bias unintentionally anyways. 2 randomized control trials, probiotics for migraine. There's 4 red squares. So if you do like maybe 2 clicks, I'll get 2 red squares. So in the 2 different studies, they used, there we go. Okay, and just do 2 more. I'll just do them all. So basically, in the first study, they gave either a capsule containing a bunch of supposedly helpful bacteria, and in another and then the other group they gave placebo. So in that study, there was no change in the migraine frequency, severity, or use of medication. So it was a negative study. In other words, the bacterial capsules, probiotics that they gave had no effect on the outcomes, the migraine outcomes that they looked at in their study. 2 years later, another group published another randomized controlled trial. It was a little bit of a larger study. Well, it was actually two studies put together, I guess, the outcome here. And they actually found that there was a decrease in migraine frequency, severity, and the number of abortive drugs used. A successful study. And I don't know why. Look, there's one key difference, which is in the top right red box, which is they did use different strains. About the same number of organisms were in the capsules. They did use. So was that the magic pill? Is that the sauce? And this is not that uncommon in science. You can basically find a study, or oftentimes more than one study, that'll show you exactly what you want to see. And it's really the accumulation of evidence over time that gives us the ability to say with confidence that something is true or not. And you really got to dig into the study. I will mention that there was a study that just was published, I think this month, that gave, it was actually another randomized control trial, placebo pills plus probiotic pills. And in their pills, they gave organisms, which were different than either of these studies, plus prebiotics. Prebiotics, I think of it as food for organisms. So it's often in like fibrous foods that you eat and stuff that you can't break down, but the organisms can grow off of that. And so in their combo, in their pill that contained both probiotics plus stuff to feed the bacteria, they had a positive outcome in there. So now we have 2 randomized control trials that are positive and 1 negative. I'd still say the jury is out, because one of the problems when people talk probiotics is, what are you talking about? Are you talking about a lot of one strain, 10 different organisms? And so, in each organism, it's like cats and dogs, and you're not going to call a cat a dog, right? We're talking about completely different organisms oftentimes here, and they break down different things. They have different processes. So not all probiotics are the same. And so it's going to take time to figure out, what's actually helpful and what's not. What's the helpful bit? That was all I had for that one. So there was a question that'll come up later related to probiotics and migraine. Oh no, I'm curious what sort of microbiome profile you see in migraine patients. So am I. That's why I'm plugging my microbiome study. That's exactly what we're looking at.
Okay, so so the way I approach my patients is in my practice, I see a lot of patients with this overlap of DGBIs and migraine. It really depends on sort of the severity of the symptoms, and really take this multimodal approach. And oftentimes patients with mild symptoms just want a diagnosis, an explanation, reassurance. It's like, why am I feeling this way? And I can't tell you how many times I've seen patients come to me with GI symptoms that are like 2 out of 10. And it's like, well, why did you see 20 doctors for 2 out of 10 pain? But it's because they've never been given a diagnosis. So, making a diagnosis, reassurance. And then in patients with severe symptoms who have, disordered sleep, anxiety, depression, other chronic pain conditions, we take a multidisciplinary approach and work with multiple subspecialists, because one person, one specialty can't take on the complexities. So in summary, functional GI disorders or disorders of brain-gut connection are common in migraine. The overlapping pain conditions are common and can negatively impact quality of life. GI symptoms may impact absorption of migraine medications. So if you're taking therapies and it's not working and you're having GI symptoms, that may be part of it. Understanding the pathophysiology of the overlapping pain conditions may provide further insight into treatment options. And this is kind of my area of interest here, is to try to understand what's that connection there. And then consider the impact of migraine therapy on GI symptoms. So ask, for doctors, ask your patients if they have GI symptoms, especially if you're starting a new therapy. And then, before we start prescribing or advising on dietary therapies, we need further studies to determine the effect of diet on symptoms and not harm. So we have to first do no harm, and dietary therapy can indeed cause harm, even though, you know, it sounds like, well, it's food, it's safe, but it's really the restriction and avoidance of food that can lead to fears and anxieties that are unnecessary. And with that, we end.
We have a lot of questions. I hope you're both prepared, but we do have, I think we have enough time to get most of them answered. So I'm going to start with a question. Some of these questions came direct message to me, so you may not all be seeing them in the chat. I think I have gastroparesis. I noticed that sometimes when I take an oral medication, it doesn't seem to work for many hours later. Address that.
I think that it's a possibility, especially if you have the symptoms of like nausea, fullness, early satiety. The only way to know for sure if you have gastroparesis is to get testing. In the US, there are 2 tests that can be done to measure gastric emptying. The most commonly available is a nuclear medicine test called a gastric emptying scintigraphy. And essentially you eat a standardized meal. Typically it's egg beaters, 2 slices of bread with jam and water, and they cook some technetium into the egg. And over the course of 4 hours, they see how long it takes for that, what percentage of that food is being emptied. So normally at the end of 4 hours, there should be less than 10% of the food remaining in your stomach. You want to make sure that there's not a standardization of these tests. So if you're going to go through the effort of getting this test done, make sure that you're getting a 4-hour test. There are some centers that do 90-minute testing. That test is worthless. So don't spend your time, effort, and money doing a 90-minute test. The other method in the US that you can do gastric emptying that's available is a wireless capsule motility. You swallow a capsule that measures pressure, temperature, and pH, and then it tracks how long it takes for that capsule to get through each of the regions. These are only done at some specialty centers, so not widely available, but measures transit through the whole gut. And this can be ordered by, the gastric emptying study can be ordered by any doctor. It doesn't have to be a gastroenterologist.
Okay, wow, very helpful. Thank you. Okay, so let's see, the first question we had, now the second question is, I've had chronic migraine since 2013. Can abdominal migraines start as an adult at age 57?
So yeah, it's increasingly being recognized that these syndromes that we previously associated with children are present in adults, including cyclic vomiting syndrome and abdominal migraine. So yes, it is possible.
Okay. Hold on. Oh, what's the connection between Crohn's and migraine? If there's a connection?
I'll just say something briefly about it. I know, so for example, as well as celiac disease. So among people with inflammatory bowel disease, which includes both Crohn's disease and ulcerative colitis, among those people, migraine was about twice as common, and among people with celiac disease, migraine was about twice as common. However, you got to look the other way too. So among people with, the best study is huge across the nation, like a national health survey, and then you say, what is the prevalence of these disorders where you're not looking for either one, and you say what percentage have migraine and what percentage have inflammatory bowel disease or celiac disease. But based on the evidence that we have, it seems that celiac and inflammatory bowel diseases are more common among people with migraine.
Okay. Well, which kind of gets related a little bit to this question. I don't know how much of the problem in the gut are caused by food allergies or intolerances. I know you talked a little bit about that, Dr. Nguyen. But I think what you said, there's not a lot of research. I know in The migraine community, I hear people talking about food all the time. Maybe Dr. Sprouse Blum, you can answer this as well about, I can't eat this, it's a trigger, but in fact, there's not a lot of research on triggers. So this is, I think, a tricky question.
It is a tricky question because, food, just eating in general can trigger GI symptoms, especially in, for example, irritable bowel syndrome, which is kind of one of the more common ones. And, with gastroparesis, eating triggers symptoms. And so any oral intake, including water, can cause symptoms. And the GI tract has dense immune cells there, right? So if you think about what's going on, is your immune system is supposed to help differentiate, foe versus friend. And when you're eating, you're introducing a lot of weird things into your body, and your immune system has learned, your gut immune system has learned to ignore the majority of that. What's being increasingly recognized is that there's mucosal immune dysregulation. So the lining of the gut, the immune cells that are there, it's not that you have more immune cells there, possibly yes, but that they're kind of reacting inappropriately to foods. Not a specific food, not like a peanut allergy or an egg allergy where you have hives, but it's these foods are triggering the immune system of the lining to trigger and release histamines and kind of pro-inflammatory mediators. So too early to say. What we do know is that these are not traditional food allergies where you go to an allergist and they do food allergy testing. So it's not that. Doing these food allergy testing kits where that are commercially available now, those have not been validated. And what I find is that it leads to ultra restriction. I mean, I see patients who are so restricted that they're eating 5 foods. And going back to the microbiome, your diet affects your microbiome. So, just 2 days of changing your diet or restricting your diet can affect your microbiome. And the more diverse your diet is, the more diverse your microbiome is.
Okay, there's a lot of those kits all over the internet now. I think what you're saying is you don't recommend those.
I don't recommend those. It's a waste of your money. And it's potentially harmful if it's leading to ultra restriction of food.
Okay, good. The next question is, what have you found with TBI in disrupting the gut-brain connection? And then also, has anyone looked at fecal matter transplants to help with migraine? 2 different questions.
Was the first one traumatic brain injury and migraine?
Yes, and disrupting the gut-brain connection.
That's bound to be a thing. I have no clue. That I'm curious to know.
Yeah, I mean, TBIs can be associated with autonomic dysregulation, and thus the downstream effects of dysautonomia with the gut. But I'm not a TBI expert, so I can't really say that I've looked into that literature.
What about, has anyone looked at fecal matter transplants to help with migraine?
I don't think so. I know that fecal, that taking good stool and transplanting it into the rectum of a person with the disease has been done in things like inflammatory bowel disease with some success, and also like Clostridium difficile colitis with success, I believe, right, Dr. Nguyen? But I don't think that it's been done in migraine. That's a bit down the road, right? Because I think people are thinking probiotics more so right now. But it's a great idea.
Yeah. So FMT or fecal microbiota transplant has been studied in IBS, inflammatory bowel disease, and C. difficile colitis. And C. difficile colitis is basically an opportunistic infection where when you take antibiotics, you kill off all the bad and the good, and then this Clostridium species takes over and causes illness. That's the only condition that FMT is FDA approved for and has been proven to be helpful. FMT has been done and studied in irritable bowel syndrome and with mixed results. So one study, what was interesting is that it, quote, normalized the microbiome, yet the IBS symptoms were not, did not improve or did not change. If anything, it got worse. All these studies that look at microbiota changes associated with certain conditions, you have to remember that inflammation affects the microbiota. So a lot of these conditions are kind of inflammatory in nature. For example, like MS is an autoimmune condition. Autoimmune conditions lead to disruption of the microbiome. So we have to be careful of, what's chicken and egg, and try, fixing the microbiome if it's not the cause of the issue. Just it's not going to be helpful. So our understanding of the microbiome is the tip of the iceberg, and a lot of the therapies that are being purported to be, normalize the microbiome is really trying to look at the base of the iceberg, but we don't have the connection between the tip and the base as yet.
Okay, thank you. Someone's asking the question, would a daily probiotic help with her diverticulitis, constipation, and diarrhea, Graves' disease?
I can say what I generally tell patients that ask me this in the headache clinic. I say that the jury's still out. They may be helpful. What you buy is very different. You can't just buy a probiotic. They're all different. What's in them is completely different. And we don't know if probiotic that you buy at CVS or at your local healthy store, whatever, that is that, and they're often expensive. Right now, what I would tell patients is eat a balanced diet. Don't go overboard with food triggers. Don't, because just like Dr. Nguyen said, patients with migraine will often feel responsible for their migraine. Oh, it was nuts. It was nuts. Now I'll stop you. Okay, no, oh, no, I got migraine. No, it wasn't nuts. It was avocado. I'll get rid of avocado. No, oh, it wasn't. And the elimination that she talked about is real. And people feel responsible for their migraine. But oftentimes, there's so many cycles that affect migraine, hormonal cycles, drops in barometric pressure, that affect your migraine that you just have no control over. And so, often the elimination can be more harmful than anything. If there's something that you eat that you consistently find is problematic, avoid it. Like alcohol is a common one. Most people say, and there's no question, they'll say, if I drink red wine, I'm going to get a migraine. There's no question. And they're not going to even ask me because they know. So eat a balanced diet, and don't go overboard with eliminating things. Sorry, Dr. Nguyen, what were you going to say?
Yeah, no, I was going to agree with that. And for GI conditions like irritable bowel syndrome, there have been lots of probiotic studies with more mixed results than you're seeing in the migraine literature. And one of our GI societies did meta-analysis, meaning what they do is they put a lot of experts who review the data, review all the data, the strength of it, pool some of the analyses, and then come up with recommendations. And essentially, the American Gastroenterology Association does not recommend probiotics at this time. And that's because of the lack of clear, strong evidence in terms of what strains. Will there be a role for it? Perhaps, but I just think where we are now, we're not ready for it. If you've stumbled upon a probiotic that has worked for you, great. But don't spend hundreds of thousands of dollars searching for the probiotic that's going to cure your condition.
Good answer. Okay. This question comes from one of our scientists in the community, and she's very knowledgeable. Dr. Beth Morton is asking, you did mention about the gammaCore device, which is actually interesting. I had no idea about treating IBS. Are there other studies being done? What else, can you elaborate a little bit more about the device?
I mean, we didn't study the device in IBS. We studied this device in idiopathic gastroparesis only. We've got a study now looking at functional dyspepsia with kind of normal gastric emptying as well as diabetic gastroparesis. There are other centers who are looking at sort of the physiology of like when you do vagal nerve stimulation, what happens to heart rate variability and gastric emptying, but they're using auricular vagal nerve stimulation. So we're in the GI world, we're very early on this in looking at vagus nerve stimulation. There is a device that is FDA approved for IBS. It's not a vagus nerve stimulator, but it's sort of a field stimulator. So it stimulates multiple cranial nerves called the IB stim. And I think it's sort of a rehashing of a device that was used previously for opiate misuse.
Okay. Someone's asking about, she's being tossed back and forth between her headache specialist and GI, GP. She talks sort of about managing headache disease, and he admitted he doesn't understand GI. So I asked him, my GP to send me GI. Will GI understand the brain-gut connection? The reason this got brought up again, because my brother was just diagnosed with celiac, and I have found gluten does exacerbate greatly my neurological issues. And I do think there's a lot of people who are going gluten-free these days with migraine, thinking, even though they don't test positive for celiac disease, that, what do you say about that?
Well, I mean, so to answer the first part of the question about, do gastroenterologists understand the brain-gut connection? The answer is yes and no. In terms of understanding, like to the degree that, Dr. Sprouse Blum and I talked about this brain-gut connection, you'll find very few neurologists who understand the gut the way I was very impressed with his understanding of the gut. And then, in terms of gastroenterologists understanding the physiology of the brain, there's not a lot of us out there, but there's an increasing awareness. And, part of, our goal is to increase that awareness. The Rome Foundation has done a very good job of, helping to promote sort of the brain-gut connection, not necessarily migraine specific, but the DGBI. So if you're looking for someone who is in your area, you can check out the Rome Foundation or IFFGD, which is another patient advocacy group who can kind of help connect you with people locally. In terms of gluten.
Could you say that again? Rome Foundation, and what was the other one?
IFFGD.
IFFGD. Hopefully everyone got that, because somebody else wants to know where to find a doctor like you. Okay, so check that out, people. Maybe Helen can try to find the link to the Rome Foundation or IFFGD. Okay, go ahead, Dr. Nguyen. You were going to continue.
And then regarding gluten is challenging because, there are different protein. When you eat wheat, there's different proteins in there, and one may be reacting to different aspects of the protein. If you're going to work on diet, restriction and going down the diet route, work with a registered dietitian who can help guide you to avoid the pitfalls of the developing an avoidant restrictive food intake disorder. So registered dietitians are licensed. So make sure you find a licensed registered dietitian to work with who's And if you find one who is specializes in GI disorders, that would be ideal too.
Okay, somebody asked, what about LPR and migraine?
Is that laryngopharyngeal reflux?
I have no idea what LPR is.
Yeah,
Maybe.
so that's correct me if I'm wrong, Dr. Nguyen, that's a condition that's thought to result from reflux of contents that can cause irritation of your pharynx, and it can, I don't know what the symptoms of it are though, honestly.
Yeah. I mean, the symptoms basically kind of hoarseness, cough. So it's gastric contents that are up in the back of your throat that can cause laryngeal symptoms, so chronic throat clearing, hoarseness, sore throat, and so the answer is yes. So any of the DGBIs that we talked about can potentially be associated with migraine. It hasn't been studied formally, so LPR and migraines in terms of prevalence, risk, not the same way we've looked at IBS and gastroparesis. But also, not everything LPR is LPR. I spend the majority of my time undiagnosing LPR or undiagnosing reflux, because the larynx is also controlled by the vagus. So the vagus nerve and the sensory fibers that send signal from the gut to the brain does include the larynx. So if you have any type of vagal hypersensitivity, that can include laryngeal hypersensitivity, where the nerves that control the back of the throat, the voice box, are sensitive to anything that you do, talking, eating, coughing, or singing, etc. So, be cautious with that diagnosis of LPR.
Okay, someone's saying they took antibiotics for a month and it was causing dyssymptomia, migraine symptoms, food intolerances, nausea, dizziness, swallowing massively increased after this. Have you ever seen this in other patients?
That's a little too specific that I'm going to defer, because there could be so many different things that are related to that. So I'm going to defer on not answering that one.
Okay. We do have a large vestibular migraine community here. Is there any difference steps that they should be taking for better gut health? Is it the same for all migraine across the board?
Yeah, I can take this one. We don't know enough about vestibular migraine to bin people in a box that we can confidently say this person has vestibular migraine. So the vestibular system is involved in balance. And so these are people that have migraine with vertigo, a sense of movement, not a disequilibrium, but a sense of movement, either of yourself or of the world. And we like to see that the vertigo attacks are tied to other migraine symptoms. As more frequent, the more, our index of suspicion that they're tied together. So we can't agree fully on a diagnostic criteria for vestibular migraine. It's kind of working its way in. So we can't say that we're studying that group of patients well enough to say much about them. It's very much an active area of research. And so no, I wouldn't approach, I don't think we've said anything that would encourage people to do anything other than, we haven't recommended any probiotics, right, particularly. We have recommended against eliminating foods. We've recommended a balanced diet, but I don't think we've said to do anything specific, right? So I wouldn't treat them any differently currently.
Okay. Are there any connections to sugar cravings that maybe stem from the gut? Someone's saying that it feels physical when she's craving sugar. I know that the sugar craving is also known as the prodrome to a migraine attack. So wondering anything else related to the gut-brain here?
So sugar actually releases dopamine, and dopamine is the happy hormone. So when you eat sugars, you release dopamine, and where that's kind of that dopamine increases in the brain is in the same area that you see lighting up with cocaine use. So if you take if you do fMRI in someone who's used cocaine and someone who has consumed large amounts of sugar, they look very similarly. You can't tell the difference between the two.
But we love our sugar. Okay, what about PCOS? Being as this is an insulin endocrine system related with high levels of cortisone production, someone saying she noticed a sharp increase in migraine frequency post-diagnosis. So I guess, is that a hormonal thing?
I mean, so when I take a history of a person with a headache disorder, the hormonal history is probably the most important aspect of the history that I take. Migraine, which is the thing that I take is kind of the bread and butter in the headache clinic, the thing that I care for most commonly, commonly pops up around hormonal milestones. So onset of periods, around 11, 12, 13 years of age, birth of a child, or menopause. And so I forgot the question. Oh yeah, PCOS. So PCOS, is a hormone-related condition, but I don't know off the top of my head if it's more common among people with migraine. I wouldn't be surprised, I suppose, but as it relates to hormones, anything hormone-related is bound to have a tie with migraine. It's so it's so common in the headache clinic that when you take a good history, you start from when they were born until the current day, that within sort of 2-ish years of one of those hormonal milestones, migraine either popped up or changed. You developed aura, your frequency changed, that type of thing. So I wouldn't be surprised if it was.
Okay, great. All right. Any relation with small intestinal bacterial overgrowth and migraine?
The answer is TBD at this point. Small intestinal bacterial overgrowth, which is, for those who are not aware, is basically bacteria that's normally in your gut, but it's stagnating in the small intestine, and there's, a higher density or concentration of bacteria in the small intestine than we would normally expect. And it can cause symptoms of excessive bloating, gas, diarrhea, abdominal cramping. And small intestinal bacterial overgrowth has been associated with different DGBIs, most commonly irritable bowel syndrome, but we also see it in gastroparesis or any disorder where we have stasis or slow motility, because the bacteria that we're ingesting on a daily basis is not getting cleared appropriately. No one's looked at the association between migraines and bacterial overgrowth to see if there's an increased prevalence of migraine or increased prevalence of bacterial overgrowth in migraines, nor do we know if treating the bacterial overgrowth makes any impact in the migraine symptoms. In those with IBS, treating bacterial overgrowth helps to alleviate or relieve the IBS symptoms, but it's not a cure for IBS. So, IBS is a risk factor for bacterial overgrowth, which can exacerbate the IBS symptoms. But again, so chasing the bacterial overgrowth as the cause of everything else can lead you down this rabbit hole of taking a lot of excessive antibiotics that can negatively impact the microbiome. So again, bacterial overgrowth is a real condition. It's something to be aware of, but not to hyper focus on it as the sole cause of the issues.
Okay. So you mentioned Zofran as a trigger for making migraine worse. I think, is that how you said it? Is there another drug that you recommend? Some people, I think, take Zofran daily. Dr. Sprouse Blum, is that correct?
Maybe
none of your patients, but
maybe we can both go on this one. You want to go first?
Yeah, so it's not so much that Zofran triggers migraines, it's the chronic use. In general, I say, limit to no more than 10 to 15 per month. Chronic use can exacerbate headaches. So if you're using, Zofran once or twice a month, not a big deal. But for someone who is needing it daily for, if they have, for example, if they have gastroparesis and migraine, and I'm finding that they're using Zofran twice a day, every day, and their headaches are uncontrolled, I may switch to something else like promethazine, which is Phenergan, or Compazine, which do not have those side effects. They have other side effects of causing sedation, but they don't cause migraine.
But you can't use those daily.
You can't use.
Okay.
So a couple answers. Can I say some stuff about that too?
Yeah, please.
So for the way I talk to patients about migraine, acute. So there's prevention to prevent headache from happening in the first place, and then there's acute treatment, right? So acute treatment is broken down into three groups. There's migraine-specific drugs. So we only had the triptan medications. Now we have G-Pens and Ditans. So we have a few different kinds now. There's anti-inflammatories, and then the third group is these dopamine antagonists. So of which ondansetron Zofran is not one. So the ones that we use regularly, they're good for both nausea and headache, including metoclopramide, which is Reglan, promethazine, which is Phenergan, and prochlorperazine, which is Compazine. And they're good for both headache and nausea. If you're having nausea on a regular basis, you should think, like on a daily basis, you probably would benefit from getting to the bottom of why you have nausea on a regular basis. If at the end of that workup, it's decided that migraine is a source of your daily nausea, then the treatment would be better treatment of migraine with better prevention. That doesn't mean we would always be successful, but we typically could be. And if nausea does not and so you can have more than one cause for nausea, right? You can have migraine, which can be associated with nausea, as well as another GI specific source for it. So that's, I guess, what I would say about that.
Okay, we have time for one more question. There was a lot more questions. I'm sorry we didn't get to everything. We did answer some of your questions that came in after. I can see some overlap here. I don't know if you answered this question, Dr. Nguyen, but is the vagal nerve stimulator used to treat abdominal migraine? Maybe you already answered that.
I mean, it's I haven't used it specifically for abdominal migraines. The data on it has been used more for headache migraines. So I can't tell you whether it could be helpful or not.
Okay, fair enough. Well, with that, we are going to bid you adieu and say thank you so much. This was a really amazing talk. And given by the amount of people here, it's obviously a very important topic that people are interested in. So thank you to the doctors. Here's how we clap in the migraine community. It's